for the very kind introduction, and good morning, everybody. I'm just going to share my screen here, and hopefully we can demystify some of the questions that arise with eponyms and echocardiography. So there are three objectives to this talk. By the end of the talk, we will be able to review the eponyms and the surgical procedures that are used to repair specific congenital heart lesions. By the end of the talk, you should understand the underlying anatomy that these surgical procedures will treat. And lastly, review imaging windows and techniques to best evaluate patients with surgical repairs of congenital heart disease. So eponyms are very common in congenital heart disease, and I'll talk a little bit about why it's an issue and why it's so common. But these surgeries that were created to repair patients with congenital heart disease were essentially the light at the end of this tunnel, this hopeless situation where these children would be born, they'd have very poor outcomes, and it was quite a desperate situation. So these pioneers and surgeons and other healthcare professionals revolutionized the care of these patients, and actually made it so that their diagnosis was no longer an early death sentence. So there was a lot of hope, and there was a lot of praise when these surgeries were created. And not surprisingly, in order to honor or to sort of classify how the surgeries were done, they were named after the surgeons and the people that created them. So it was a sort of an honorific thing to do. And it's very common in medicine. We have this with a lot of other things. But the problems with eponyms in congenital heart disease and anything is that eponyms don't reflect the underlying problem. They don't reflect the surgical procedure that was done because it's named after a person. And it doesn't necessarily reflect reality. Typically, these eponyms are named after one person, but it does take a team of people to create the surgical procedures and manage these patients. So although they're great, and although it's done to honor people and to memorialize the work they did, it can be difficult for us in the echo lab when we're trying to figure out exactly what we're looking at. But we will go over these. And I do want to touch on why we should care about these procedures, why it's important for us to have an idea about them. We know that the population of adult congenital heart disease patients is growing. And interestingly, the complex group of those patients is increasing faster than the other groups. And so this is some data out of Quebec, so it's Canadian data. What this shows is the prevalence of congenital heart disease in adults and children, adults being the red bars here, children being the blue. I promise this is the only graph. And what we can see is for all congenital heart patients, the prevalence from 2000 to 2010, so this is quite old data, shows a significant rise in the number of adults with congenital heart disease compared to kids. So adult group is growing faster. And that's because these patients are surviving to adulthood, and in adulthood, they are living longer. What's also interesting and quite relevant to us in this talk is that when we look at the complex patients, so the patients that otherwise wouldn't have survived to childhood before these procedures are now surviving, sorry, wouldn't have survived to adulthood. Now they're surviving to adulthood, and their prevalence is growing. And so it is important for us to understand that these patients are out there, and we are going to be seeing them at some point. And the reason it's relevant to all of us here is that there are more patients with adult congenital heart disease than the subspecialized cardiologists and programs are able to care for. Right now in Canada, there's an estimated greater than 187,000 of these patients, and less than 1 in 5 of them is in a specialized care program. So they are out there, and you will see them, whether it's in your clinic, in emergency, or in the hospital. Echo is the most frequently used imaging test in congenital heart disease. So it's very, very common, and usually the first line when evaluating a patient that's having a problem. So the reason why we should all care about this is you will see these patients in your practice, and having an understanding of what's going on is very important. So there are many surgical procedures named after people, after physicians. Here are some of the more common ones. We're not going to go through everything today, but I was going to highlight some of my favorites. Specifically patients that have transposition of the great arteries, because there's been a lot of surgical technique changes over the years, and we'll go through the different techniques and the imaging that is quite different between And we'll also go over some of the more complicated systemic venous to pulmonary artery connections. These are our Glenn shunts and our Fontan. And then lastly, we'll end on sort of the most complex of the complex, which is our Norwood procedure. So for every patient, when I was going through my training, it was always important that we needed to understand the original anatomy because it gives us an idea about how to interpret what we're seeing. We're always encouraged to review the surgical notes and the history to know what to look for. Ideally, previous images and windows when you're scanning to figure out where they were able to see the best pictures. And I was always told never to begin a scan unless you understand the anatomy. So we'll jump right into the repair of transposition of the great arteries. So this diagram here is a figure of what transposition of the great arteries or detransposition looks like. And we hope we can all appreciate that you have venous blood going into a subpulmonic right ventricle, so a morphologic right ventricle, and then that would connect to the aorta. And then you'd have the pulmonary venous blood coming back to the morphologic left ventricle on the left side, and that was connected to the pulmonary artery. So this condition is non-compatible with life. And when surgical procedures began to try to treat these children, the first one that gained a lot of ground was this Mustard or Senning. It was actually Senning who was the first one to create it, and then done in Canada by Dr. Mustard, which I think we're all familiar with. Essentially, in order to repair the transposition of the great arteries, the surgery, so the Mustard and the Senning, baffled the blood from the SVC and the IVC towards the subpulmonic left ventricle, and the pulmonary venous blood got baffled towards the subaortic right ventricle. And we'll go through this in a little bit more detail. Now, after many years, it was noted that this surgery wasn't the best for outcomes, and other variants of the surgery were created. Another option that was done at the time was a Rastelli type repair, where if a large VSD was present, a baffle was made from the LV to the aorta in order to maintain a systemic left ventricle because we felt that was better, and then an RV to PA conduit installed. Now, more commonly today, children or infants that are born with TGA will undergo the arterial switch procedure, also known as the Jatene procedure. So this is by far the most common procedure that we see in very young people, but there's definitely a lot of patients out there with the Mustard and Rastelli procedures as well. So when we look at, okay, what is this Mustard or Senning procedure? So it's done for detransposition of the great arteries. It dates back to the 1950s and 60s. And essentially, as I mentioned, the repair is a baffling of the IVC and SVC blood to the mitral valve or subpulmonic left ventricle. And then the pulmonary venous blood gets baffled to the right side of the subaortic right ventricle. So essentially, blood to the lungs is from the left ventricle and blood to the aorta is from the right ventricle, and giving you a systemic right ventricle. And this is Dr. Mustard here and Dr. Senning who created the procedure. So it's important to also know that this was performed in Canada up to the 1980s. So this isn't some remote procedure that was done long time ago. I still have many patients that have this procedure done, and there's many of them that have been lost to follow-up and are still in the community. So you may very well see somebody like this. When imaging a patient with a Mustard or a Senning procedure, so this is the atrial level switch, our parasternal long axis view will typically show us a dilated and hypertrophied right ventricle with a very small and squashed left ventricle, you can see here. We can see the great arteries in parallel. And then when we show a 4-chamber view, we'd be looking at the size and function of that systemic right ventricle, as well as valvular function, because AV valve regurgitation can be very problematic for these patients in the development of heart failure and arrhythmias. A normal view in the short axis here would show us a very compressed or banana-shaped left ventricle, and that's good. We want to see a compressed left ventricle because anything that shows dilation or a circular left ventricle would be concerning for either volume or pressure overload of that left ventricle. And our short axis view, when we go up to the aortic and pulmonic valves, you'll typically see the aortic valve anterior and the pulmonic valve posterior. And we'd be looking here for valve function and any evidence of regurgitation. The next point we want to evaluate in patients that have mustard or Senning procedures is the baffles. So as I showed you in the image before, they redirect blood flow from the SVC and IVC to the respective ventricle. And we need to evaluate if those connections are, number one, patent, or if there's any evidence of leak. So in order to do the baffle evaluation, we need to understand the views where you're best going to align with the baffles and what the way to interrogate them is, or what the most useful way to interrogate them is. So in this view, our parasternal long axis view, we have our SVC baffle typically will follow right behind the pulmonary artery. And so if we can align using pulse wave, we want to pulse that baffle to see if there's normal low velocity flow. And that would show us that the baffle is patent and there's no stenosis. For our IVC baffle, this will typically be in an off-axis 4-chamber view. So you may angle either slightly posterior, anterior, depending on where the surgeon put the baffle. And you can see here this structure coming in from the IVC towards the left ventricle. This is the mitral valve over here. And if we pulse this baffle here, you can see that the flow velocity is less than 1 meter per second. And that would be considered a normal flow velocity. So that's our IVC baffle there in the tilted 4-chamber view. And we've got our, as I mentioned earlier, the SVC baffle up behind the pulmonic valve. And so normal flow velocity is typically less than 1.5 meters per second. And as we're interpreting these studies, it's important for us to comment on this. When we look at the pulmonary venous baffle, so that's the other side of the baffle that redirects all of the blood flow from the pulmonary veins to the right atrium and therefore the subaortic right ventricle. We want to have a off-axis 4-chamber view, and hope everybody can appreciate here there is a nice open connection there from the pulmonary veins into that right atrium. When we pulse these, again, this image here shows nice low velocity flow from the pulmonary veins and then through the baffle. And so the considerations we'd have when imaging these baffles is, well, if you don't know what baffle you're looking at, a nice trick is to do a bubble study, because the SVC baffle will light up with the baffles when the IV is in the arm. And this is another way that we can do to check for baffle leaks. So we will check for baffle stenosis, and we can check for baffle leaks if we're clinically concerned for that by using a bubble study. So some of the complications that you might see in a mustard patient, this would be an example of an apical 4-chamber. We can see our systemic right ventricle there, which is hypertrophied and dilated. And then in this off-axis view that we have here, what I hope everyone can appreciate is that there is flow acceleration in the level of the IVC baffle here. And so when our sonographer went on to pulse this baffle, we found that on pulse wave Doppler that the flow through the baffle was greater than 1.7 meters per second. So this would be consistent with a stenosis through the baffle, and something that would need to be dealt with from an interventional or surgical point of view. Another complication that we might see, this is a patient short axis view in a mustard patient. We can see our hypertrophied and dilated right ventricle on top and our D-shaped septum with the left ventricle. Now, this ventricle, although there is a D-shaped septum, it doesn't look like that nice squashed banana that we like to see for the mustard and Senning patients. And when our sonographer went on further to do a sweep of the baffles, they found something that was concerning for atypical flow seen in the area of the SVC baffle. So because the LV was larger than it should be, similar to a patient that would have an atrial septal defect and volume loading of the right ventricle, in a mustard, there can be volume loading of that subpulmonic left ventricle. And so this color flow was concerning enough that there was a hint that there could be a baffle leak. And so in this patient here, just to show you side to side what our problematic LV looked like and what a normal LV looked like. So this dilated left ventricle caused us to do further imaging tests. So we started off with a bubble study that was done. So most bubble studies in most echo labs typically happen with an IV in the arm, and that's what was started off here. And I hope everybody can appreciate that the IV in the arm had bubbles going through the SVC baffle. into the subpulmonic left ventricle, and we don't really see any major bubbles in the systemic ventricle here. So IV in the right arm. And just to remind everybody what the surgical procedure was, here's our baffles. And then we had bubbles going in through the SVC limb of the baffles. And in this case, we did not see any leak. So we did not stop there. The next part of the study, we had an IV placed in the patient's femoral vein, and then perform the same bubble study to interrogate the IVC baffle. And I hope everybody can appreciate here that this is positive for a pretty large baffle leak that we can see in the SVC baffle and the IVC baffle there. And to remind everyone what we're interrogating, the bubbles are coming in from the leg. We're interrogating this IVC baffle, and that's where the leak was found. We can appreciate it just right there on the screen. So when evaluating those patients, as I mentioned, it's important to look for stenosis, it's important to look for function, it's also important to look for leak if you're concerned. The next procedure we're gonna talk about is our Rastelli procedure. So this was done for patients with detransposition of the great arteries that had a large VSD and typically pulmonic stenosis. It was started in the late 1960s, and basically this procedure is done by tunneling the left ventricle to the aorta in order to maintain a subaortic left ventricle or a systemic left ventricle, and putting an RV to PA conduits to the pulmonary arteries. So imaging these patients is not that difficult. We see here a parasternal long axis view, and what's somewhat different than our typical patient with normal anatomy is that you do need to take time to image this LV tunnel. And so here we have our aorta coming off of the LV tunnel and the left ventricle down here. When we zoom in on that aortic tunnel, what you can appreciate is that there's a calcified patch that redirects blood in the LVOT towards the aorta. And so the considerations that you'd have when imaging a patient with a Rastelli procedure would be to make sure there's no LVOT obstruction, to evaluate for any endocarditis or VSD patch leak, and to look for aortic valve function. Now, because the aortic valve isn't lined up properly due to the TGA, using off-axis views can be very helpful. So this is an example of a right parasternal view here, where they're able to show the ascending aorta and the aortic valve. So these non-conventional views can be very useful, and this is why looking at old images to see how they did the study last time can be helpful. So because the angulation is improved in this view, we lined up our Doppler and got our view of our mild AI and no evidence of stenosis. More challenging in these patients is imaging of the conduits. The conduits can be very difficult to see because they're quite anterior, but this is where using either a very anterior angulated transducer or even a right parasternal view can help you visualize the conduits. So this RV to PA conduit here, we can see a nice view of the valve. Typically, we don't have such great views, but that right-sided window can be useful. And we'll evaluate function typically with our Doppler, PW, and CW. But the trick with the conduits is to either reposition the patient or use sort of off-axis views or non-standard views to visualize things. And here we line up our CW, and you can see we've got nice flow. When looking for complications in patients with Rastelli procedures, so this is a different patient here, a parasternal long axis view where we've zoomed in on that LVOT tunnel. And when we put color on this patient, I hope everyone can appreciate that there is a significant amount of color flow seen through the patch. If you would see something like this, I'd be very concerned that there's a patch leak, and further evaluation would be needed. So same patient here, we have a short axis view, and not surprisingly, the views can be challenging in congenital heart patients with their multiple surgeries. But in this patient here, they were able to show in the short axis that there is a leak in that LV to aorta tunnel that's causing excessive blood flow onto the right side. Okay. So we come now to our Jatene arterial switch procedures. So this is the most common type of procedure done for TGA or DTGA in this day and age. And it was started, or it was first described in the late 1970s. And in the 1980s, it began taking over as the primary surgery of choice for a DTGA. And it's a little bit more complicated technically, coming from a non-surgeon, than than the mustard because there's a lot more switching of things, but it does provide the patient a systemic left ventricle, which we believe will have better long-term outcomes. And so how this was done is that there's a transection of the proximal ascending aorta and pulmonary artery. The pulmonary artery is now moved forward and draped over the aorta, and that's the Lecompte maneuver, which we're going to talk about in a few minutes. There is relocation of the aorta to the LV, pulmonary artery to the RV, and then reimplantation of the coronary arteries. And it's important as echocardiographers that we remember the coronary arteries because ischemia can be one of the ways these patients present. And so in a arterial switch procedure, essentially you have a systemic left ventricle and a subpulmonic right ventricle. So your anatomy is corrected, but there are complications that we need to be able to look for. So imaging these patients is similar to a standard echo. There's not that many different views you need to do, but as readers and scanners, we need to pay attention to certain things. Here's a view parasternal long axis, and I hope everyone can appreciate that there's parallel great vessels still. And what we see here on color is there's mild neo-aortic valve insufficiency and mild neopulmonic valve insufficiency, but otherwise no significant flow acceleration or leak. And so the main considerations for evaluating patients with the arterial switch is you want to evaluate for supravalvular aortic stenosis and pulmonic stenosis because that's the anastomotic site, as we can see in the diagram here. You can look for neo-aortic and neopulmonic valve regurgitation or insufficiency, which can be a complication. You can get neo-aortic root dilation specifically at the surgical site. And importantly, we want to make sure we're evaluating for ischemia. So this can be done looking for LV dysfunction, and at times we will also do stress echoes in these patients to look to see if the reimplantation of the coronary arteries has resulted in ischemia. So one of the pieces of this arterial switch procedure that's important for us to be able to understand and interrogate correctly is the Lecompte maneuver part of it. And this is how they move the pulmonary artery that originally was posterior. They bring it forward. And in doing so, they can stretch the pulmonary artery, particularly the branch pulmonary arteries a little bit, which can result in branch pulmonary artery stenosis. So in this view here, this is an RV outflow view. We can appreciate the pulmonary valve and the main pulmonary artery. And what you see here that's different in the Lecompte maneuver than in normal anatomy is you've got your branch PAs that are essentially hugging the aorta. So this is the aorta, the circular structure here, and you have your RPA and your LPA that are going on either side of it. And this is an area where you can get branch pulmonary artery stenosis. So with this arterial switch procedure, we do want to make sure that we're doing a pulse wave and an evaluation of both branch pulmonary arteries. You can see here, this pulse wave shows flow at about 1 meter per second through the branch RPA, and then LPA was slightly higher. So a bit of narrowing in the LPA was suspected here. This is just a description or a graphical description of how they do the translocation of the roots and reanastomosis of the coronary buttons and this draping of the pulmonary arteries over the ascending aorta. So when we're imaging it, we look for branch PA stenosis. It's important to interrogate with both PW and CWs in the MPA and the branches. You can look for flattening or distortion of the main pulmonary artery as well as dilation. And to give you a view from CT, just to help cement what we were looking for in your mind, this is what the view is. You have your main pulmonary artery with the branch PAs that are draping across the ascending aorta. And in this reconstructed figure here of a patient with this procedure, you can see that there's narrowing of that LPA and there's LPA stenosis. And so with our hemodynamics, we can use Doppler to help evaluate for this. And the Lecompte maneuver is not unique to transposed great vessels or not unique to the arterial switch. It's seen in a bunch of different procedures. So it's possible that you may see somebody that's had this as part of a surgical repair for something else. I'm not going to go into great detail, but here's a list of other procedures that this Lecompte maneuver may be seen in. So now we'll jump into our systemic venous to pulmonary artery procedures. I'm really going to focus in on the Glenn procedure and a few of the Fontan procedures. We'll start off with our Glenn anastomosis. Now, the Glenn shunt was done to offload or bypass the right heart. It's done for multiple different things. It could be done in univentricular circulations. It can be done in patients that have Ebstein's anomaly of the tricuspid valve, or people that have hypoplastic right ventricles. In some cases, it may even be done for tricuspid valve stenosis. And so in the classic Glenn, the SVC was connected directly to the RPA after transecting it. And this allowed bypass of some of the venous blood up to the right heart. The problem with the classic Glenn is that AVMs would form in that right lung because the blood did not pass through the liver. So the more common Glenn that we see in this day and age is our bi-directional Glenn anastomosis. And that's a little bit more straightforward. Essentially, the SVC gets connected directly to the RPA. And then venous blood from the SVC will go to both right and left pulmonary arteries. So that's the typical end result of a Glenn shunt. It doesn't tell you where the blood to the aorta or the blood to the lungs goes from the IVC, but a Glenn shunt is basically just SVC to RPA connection. And when we're imaging this, sometimes some off-axis views can be helpful, but what we like to see when evaluating a Glenn shunt is nice unobstructed venous flow. And the best view I've found for this is assuming it's a right-sided SVC, is the right supraclavicular view. So this is where you take your transducer and you put it right into the right clavicle area. And then as your color flow gets turned down, you should try to see this nice unobstructed venous flow. But it is important to bring the color scale down because it can be a bit confusing with the aorta in the same area. So we want to look for nice venous flow. And ideally, we want to line up our Doppler and do a pulse wave to look at the flow velocities within that connection that was created. We can also see the Glenn's connection to the RPA, and we look for flow acceleration in that area to make sure there's no stenosis. So when doing a pulse wave of the Glenn shunt, what we like to see is low velocity respiratory phasic flow. That means that there is an unobstructed venous connection from the SVC to the RPA. So this low velocity flow and with respiratory phasic changes is very helpful because it shows us essentially that the connection is patent and unobstructed. When we move on to something a little bit more complicated or taking that next step, we can talk about our Fontan circulation. Now, what's important to understand about Fontan isn't a heart lesion. It is a type of circulation that the surgeons can create, but it doesn't tell you how they created it. Basically, what Fontan is a complete bypass of the subpulmonic ventricle. So all venous blood in a Fontan circulation, however it gets done, is connected directly to the pulmonary arteries. So we'll walk through several of these, but this would be an example in the anatomy of tricuspid atresia of how you can redirect venous blood flow to the pulmonary arteries through either right atrial to pulmonary artery connection. You can have a Bjork variant where you can use remnant RV as a conduit. You can have our lateral tunnel Fontan where we put a baffle within the right atrium. And then more commonly now is our extracardiac Fontan where we have a tube graft going from IVC to pulmonary artery. And what's important in all of these lesions is that you need to evaluate the circuit flow. And turning down the color scale can be very helpful because you are looking for low velocity venous flow. So turning the scale down to about 40 is usually helpful. We do recommend PW of the SVC and IVC and any conduit connection to look for low velocity respiratory phasic flow. Because if you find that, it's likely that the Fontan is not obstructed and it's patent, and we're happy with that. So jumping into the surgery, so Fontan and Kreutzer first described this connection of the right pulmonary artery, the right atrium to the right pulmonary artery. So this is back in the 1970s. So it might seem like a long time ago, but I assure you this is not that long ago, at least not speaking from a surgical perspective. And so it is typically a non-valved conduit between the right atrium and the pulmonary artery, and we transect the pulmonary artery so that there's no flow from the ventricle into the PA any longer. And so this tells you nothing about what the systemic ventricle is, but it does tell you that all venous blood flow from the head and the legs goes into the right atrium, then gets connected to the RPA. And when imaging these patients, what we will typically see here is a very dilated right atrium. And because of that, there can be stasis in the right atrium because there's a pooling, or it acts kind of like a lake. And we look for smoke and we look for thrombus. And we want to evaluate for the size of the right atrium and if it's compressing any associated structures. So in the diagram I've shown you here, I've tried to demonstrate how this tricuspid atresia patient that we have in apical 4-chamber view here, you've got this dilated right atrium, which is acting like our conduit to the pulmonary artery. So that would correspond to this part of the graphic here. And we have our ventricle with the VSD that we see up here. So in evaluating this person, we would look for the size of the right atrium, we'd look for smoke, any evidence of thrombus, and any compression of associated structures. When we do a short axis view of these patients, it's also helpful for us to image the connection of the right atrium to the pulmonary artery to make sure it's unobstructed. And in this case here, our right atrial appendage connects into the pulmonary artery in the inferior part of the image. We can put color flow on there. This can be quite challenging to visualize because we're perpendicular to it with our Doppler. In this case, our sonographer did try to pulse wave. However, it's not a great angle, but it does show us that there's no high velocity. So that's our connection there to the pulmonary artery. If you find that you're not able to get a good angle, then the Doppler signals are not going to be as reliable and may not be helpful if reported. So this is another patient with the same type of repair. It's an RA to PA Fontan, and a very different outcome than the one I showed you in the slide before. What we can see on this patient is that the right atrium is now massive. It's actually greater than the rest of the heart. And what we see in here is very, very slow, sluggish flow and evidence of an organized thrombus within that RA. So this is a very bad finding for a patient with Fontan circulation. Because of complications like dilated RA, arrhythmia, and thrombus, surgical technique for Fontan circulation did change over the years. And in the late 1980s, the lateral tunnel Fontan became more popular. And this was to avoid that massive dilation of the right atria and to minimize the risk of thrombus. So similar to the RAPA Fontan, all the blue blood, all the venous blood gets connected directly to the pulmonary arteries. But how they did it with the lateral tunnel is a Glenn shunt is created, so SVC directly to RPA. And then the venous blood from the IVC gets baffled in the heart using some type of surgical material to the RPA. So essentially all the venous blood is connected into the pulmonary arteries and it's done through a baffle. So it doesn't really tell you anything about what the systemic ventricle is, but a lateral tunnel Fontan is essentially a Glenn shunt and a venous baffle for all blue blood to go to the pulmonary artery. Imaging these patients, you want to look for things like baffle leak or baffle stenosis. So in a subcostal view of a lateral tunnel, what we can see here is that the IVC is coming in and we see our baffle here, or this surgical material that was placed in to redirect the venous blood towards the pulmonary artery. So we would look for a leak in that area using color Doppler. You could look for thrombus as well. In our, I'll use the term loosely, but our apical 4-chamber view here, what we see is the part of the right atrium that's in the lateral tunnel, as well as that surgical baffle. And we would look here again for a leak or thrombus or stenosis. For another evaluation that we can do to better evaluate the length of the baffle, we can do a deep modified parasternal long axis view. And what we see here is there's our systemic ventricle, and this structure behind the heart is actually the lateral tunnel. And when we throw color on there, you can see that there is some venous flow in there, and it is lower velocity. So that tunnel there can be interrogated for leak. It can be interrogated for thrombus. And the smoke or thrombus is very concerning. In order to better evaluate it, it is important to remember to turn your color scale down to make sure that you're looking for venous flows. And when you are looking for the PW venous flows in those structures, it's helpful to increase your sweep speed to show a few respiratory cycles. Any flow acceleration or lack of respiratory variation can be a concern for stenosis or thrombus in the conduit. So more commonly now, we do extracardiac Fontan. So these are IVC tunnel or IVC graft material to the pulmonary artery and a bidirectional Glenn shunt. So again, this is a total bypass of the subpulmonic ventricle with all venous blood getting plugged into the pulmonary arteries. And when we're imaging these patients, we need to check those connections. There is this extracardiac Fontan really doesn't tell you anything about the underlying anatomy. It just tells you that all venous blood is connected into the PAs, and in this case, through a tube graft from the IVC and a bidirectional Glenn. When we look at our extracardiac Fontans, here's our apical view. We can see a nice, small, rounded structure here. That is the conduit. And we can evaluate that conduit for baffle leaks, or at times there's fenestrations that are intentionally put in there to offload and improve the cardiac output. And so we would evaluate those if present. In a deep modified peristernal long axis view, you can see that conduit here behind the heart and it's a single ventricle. And when we put color flow here, again, you can see that nice venous laminar flow in the conduit. So the imaging isn't particularly complicated if you understand where the structures are. So there's our extracardiac Fontan. Now, when taking a look at the IVC and SVC, so in this case up here, we've got our SVC, that's our right supraclavicular view. As I mentioned earlier, we want to do a pulse wave looking for that respiratory phasic flow. We will also do this in the IVC, and again, looking for that nice low velocity phasic flow that we see here. And just to remind everybody that to bring the scale down, it can be helpful. And the structures in this case that we're imaging here are the SVC and the IVC. If you can find the connection from the conduit into the PA, that's also helpful to image if available. And that connection here may look something like this. So this is a modified peristernal long axis view. That's the conduit coming in, and this is the right pulmonary artery here. That's the venous blood. And in this case, we were able to show that once again, we've got low velocity respiratory phasic flow. So depending on how you find it, it can be helpful to image it in a few different views. But the easiest ones, if you can't find that connection of the conduit into the pulmonary artery, is to get the SVC and the IVC. If they're low velocity respiratory phasic flow, you're likely looking at patent connection, no stenosis, no thrombus. All right. Lastly, we're going to jump into the hypoplastic left heart syndrome. And there's not a lot different in the HLHS repair or the Norwood repair than in a Fontan. There's just reconstruction of the aorta. What's important to understand is that there is a large cohort of these patients that are now coming into adulthood because the surgery in order to repair hypoplastic left heart was performed in the late 1970s and typically took on more a prevalence of the surgery in the 1980s. So personally, as a congenital heart doctor, I'm getting a lot of these HLHS repaired patients coming in their early 20s now. And so we're going to see more and more of them, and we're going to see more of them as they survive into adulthood. So the Norwood procedure that was used to repair the hypoplastic left heart, as I mentioned, it was done in the 1970s, late 1970s, done more in the 1980s, and it takes 3 stages. Now, as an echocardiographer, I don't know that understanding all the 3 stages and the timing of them is as helpful as what was done. So essentially, by the end of the Norwood, you should have, or the person would have, a extracardiac Fontan. So that's the bidirectional Glenn with SVC to RPA and that conduit from the IVC to the RPA. It may or may not have a little hole in it to allow offloading and improving cardiac output. There is a reconstruction of the aorta. Typically, the aorta in these patients is hypoplastic, so they use the pulmonary artery to rebuild the aorta. And we'll usually see an anastomosis between the native aorta and the new aorta, which is the pulmonary artery. And so this connection here is known as a Damos-Case-Stansel connection, or DKS. And so that's something else that needs to be imaged because both outflow tracts can become regurgitant. But essentially, it's a Fontan procedure that has several more steps. The other important thing to image, and we'll talk about this in a moment, is imaging the arch to look for any evidence of obstruction as it is reconstructed. But in a Norwood procedure, the end result is that blood to the lungs comes from the SVC and IVC through that Fontan connection, and blood to the aorta is from the right ventricle. So not surprisingly, when you're imaging these people, making sure you get a view of the RV, the function, and the size is very helpful. So in the adult hypoplastic left heart repair, we can see here our parasternal long axis view. We have a very hypoplastic left ventricle, mitral valve, and the aortic valve has atypical motion. When taking a closer look in this patient, we see that the valve is likely unicuspid and probably the reason why there was hypoplasia of the left heart, because there was stenosis through that valve. Imaging them and our apical views, we do want to get as good a view as possible of that systemic right ventricle to look for function. And importantly, we want to know the function of the systemic tricuspid valve because regurgitation in this valve can cause heart failure and difficulties with the whole circuit. As you can imagine, your entire cardiac output is reliant on low velocity flow of venous blood going directly into the lungs. If anything increases the end diastolic pressure of the ventricle or increases the pulmonary artery pressure, your cardiac output is going to go down because you can't force blood into the lungs because it's all passive flow from the veins. So as I mentioned, the hypoplastic LV and mitral hypoplasia. And the other piece to imaging these patients, as I mentioned, that Demos case stancil anastomosis, or DKS, it's essentially looking at both outflow tracts and seeing if they are anastomosed together. So in this picture here, this is an off-axis, short-axis view. So we should ideally be seeing the aortic valve over here and the pulmonic valve more anterior, and they are, but they are connected to one another as well. And so that DKS anastomosis is visualized here with color flow. It's nice and patent. There's no stenosis, so that's good. And this on the graphic would be what we're looking at. The next, further on in the study, you want to make sure you're evaluating that reconstructed aortic arch. Similar to when you're evaluating for a coarctation of the aorta, we want to get nice color flow over the arch with CW and PW to look for any evidence of stenosis. And so when we're imaging this area, this is an example here of a CW, and what we see is the velocity is high, but there's no antegrade diastolic tail. So if there's no flow that's going on in diastole, no antegrade flow that you would typically see in like a coarctation. So that sawtooth pattern of a coarc, we're not seeing that here. So even though the velocity is a little bit elevated, I'm not concerned that there's obstruction here. That would be something else to comment on. So similar to the other Fontans that we talked about, we do want to do those PWs of the venous connections. That's the SVC, the conduit, if you can find it, and the IVC. And what we see here is our nice low velocity venous flow with that respiratory phasic variation showing a patent connection. And just to orient everybody once again, the SVC PW would be around here. The conduit one would be in that area before the connection to the pulmonary artery. And lastly, the IVC is going to be in the IVC. So there was a lot of surgeries that we went through, and the hope is that this isn't going to be a completely comprehensive discussion about it, but just to go over as an overview the types of surgeries that are done and some of the key themes and things that we need to image when we're evaluating these patients to look for any long-term complications. So our operations for the detransposition of the great arteries, we reviewed the mustard, the Senning, that's our atrial switch. For the Rastelli procedure, that's our LV to aorta tunnel with RV to PA conduit. And the Jatene, so by far the most common repair that you're going to see in young people these days. So most 20-year-olds will have the Jatene procedure. And that is our arterial switch, where we're evaluating for supravalvular stenosis, evidence of neo-aortic or pulmonic valve insufficiency, and evidence of ischemia. For the systemic venous to pulmonary artery connections, we reviewed the Glenn, that's SVC to pulmonary artery. We reviewed several of the Fontan procedures, which is essentially a complete bypass of the subpulmonic ventricle. And we did cover briefly the Norwood procedure for sort of the most complex out of the complex patients that are repaired these days. So in summary, many repairs are named after physicians. Procedures named after a physician usually means that the patient has complex congenital heart disease. So if you're not familiar with this, ask for help. And if the patient has something that has been imaged before, please look at the old images. It may help guide you on the study that you're doing today. We know that proper understanding of anatomy and repairs are required to adequately evaluate these patients. Just commenting on the ventricular and valvular function is not always sufficient. As I showed you in this talk, if there are conduits, you need to look for stenosis, you need to look for thrombosis, you need to look for a leak. So understanding how the patients are repaired is very important to making sure that we're doing our best job in imaging them and caring for them going forward. I want to thank everybody for your attention this early in the morning with a topic that's somewhat complicated. And if you do have any questions, I'd be happy to answer them.
Thank you, Robin, for a very comprehensive review of all the eponyms that we often encounter during our echo scanning. And it brings back all the memories of Royal College examination. Which is very important because we need to know what they are, and we still see these patients. Without further ado, let's see if there are any questions from the audience.
Stunned silence, maybe.
Maybe I often start off with the first one and stimulate everyone's interest. So, I mean, one of the problem is that, like, we face with this kind of situation is, like, you know, as a general cardiologist or echo lab that's not particularly specialized in congenital heart disease or adult congenital heart disease, and then you often see them one off. So how will you be able to actually keep up with the knowledge and, you know, figure that out, or like, you know, how do you get a lifeline in the middle of all this when you're scanning?
Yeah, that's a great question. I think in Toronto, you are lucky because there's so many hospitals so close together. And there's definitely people around that you can reach out and ask for help. I think having a general understanding of what to look for is important because these patients can get sick. And if there's an emergency problem, be it either cholecystitis or pregnancy or whatever, they may not necessarily go to the super subspecialized hospital. I also have had patients that have been lost to follow-up for several years with their Fontan circulation. We're told that they needed an echo by someone and come into a general echo lab. And the team there wasn't prepared because they didn't know what the anatomy was, and they reached out for help. And so having a colleague or having a network of people that understand and care for these patients every day can be very useful. You know, obviously I'm going to encourage everybody to keep up with some of the more common anatomies because it may walk into your lab, especially the detransposition with the Jatene repair. As far as I'm concerned, that's a fairly straightforward patient once they're repaired. So that doesn't necessarily need a subspecialized lab to be imaging them. But I guess in order to answer your question is, number one, have some general familiarity of what to look for, because you're right, if it's a one-off, you at least want to look for big picture things. But number two, ask for help. In Toronto, there's the group at the general, there's somebody on call all the time. Where I'm from, usually I get a panicked text or call to deal with these things, and that's okay. I think in general, if you need help, it is available. And there are lots of resources online. If you're seeing this person and it's not an emergency and you want to go through the anatomy, that CHD diagram site does go through a lot of the anatomy, which can be helpful as an imager to make sure you're going through the study completely. But I would encourage everybody to sort of have a basic understanding of these lesions because there's way more patients than the subspecialty care centers are able to care for. And so I think that more places, especially larger hospitals, are going to be seeing patients coming in with either cardiac or non-cardiac problems, and having the teams there at least familiar with the anatomy is going to be important.
Completely agree. We also very fortunate to have a pediatric cardiologist who work very closely with us. So whenever I get in trouble, then I go and help me out and look with me, which
Absolutely
to where. Okay, any questions from the audience?
Hi, Robin. Thanks for the talk.
Hi, Howard.
You know, thanks for allowing Chiming to post on the YouTube. I think this will be a good resource. You know, if one of these patients do come to the lab, to help us work through some of the issues that you've talked about. So thank you for that. One question I had for you was, you know, in your practice or in adult congenital heart disease, has 3D transthoracic echo helped at all with regards to some of these aspects that you've talked about in terms of looking at these patients post correction, or not really? What's the uptake?
So I guess the short answer is yes, but the caveat is when you can get the images. Sometimes these patients can be very difficult to image just based off of previous surgical scars and anatomy and the chest wall, especially any structure that's anterior. It's quite difficult to look at. But we have used 3D to evaluate systemic ventricular function in some cases, as well as AV valve regurgitation and leaks. I found 3D a little bit more helpful when you're doing a transesophageal echo, which is a whole other world. But it's not as like we try to do it in our lab, but most of the time we're limited by imaging. But I like 3D ejection fractions. I like looking at a 3D assessment of the valves when you can get it.
Yeah, I was also thinking about use of X-plane or biplane imaging for
Absolutely.
conduits, for example, that could
Yeah.
be a little bit off axis. Yeah, that do you find that useful as well?
Yeah, we do. It can also help us, especially when you're trying to figure out which off-axis view is best. If you can get a view that you see things reasonably well in, and using that biplane, it can help you adjust to further visualize things. So absolutely, biplane can be an invaluable tool.
Great. Thanks again, Robin.
Thank you.
So how about using echo contrast? Is there any particular caution among patients with congenital heart disease? And also, I know you are an expert in women with a pregnancy. Is that a concern as well, like with using contrast in that?
So when I think of contrast, I think of both bubbles and like Definity. For bubbles, no concern. I mean, in general, the bubbles can be very helpful for figuring out where your conduits are and what's connected to what. In pregnant people, we will do bubble studies, but really only if it's going to change management in pregnancy. With respect to Definity, in congenital heart patients, I do use it. You just have to be careful not to inject large bubbles when you're injecting somebody that has a shunt. In pregnant patients, I have not used Definity because it hasn't been studied. However, there are, it's always going to be a risk benefit. If the patient needs it because of some major problem, or it's going to change your management and they're pregnant, there's going to be some risk benefit discussion with them. But in general, Definity has not been used in the pregnant population because it hasn't been studied effectively.
Any help from the artificial intelligence world in terms of helping with this really complicated topic?
I think that's a good question. I think the AI has typically been focused on normal anatomy. And what I hope would happen in the future would be having the ability of AI to compare previous images, because I think sometimes it can be difficult, especially when patients are coming in and imaging windows maybe aren't as good one day, or they can't be positioned a certain way. And it can be challenging to visualize that systemic right ventricle or other structures that are, definitely three-dimensional structures that aren't quite as well evaluated on 2D. If you had AI as a tool to help follow things serially over time, that might help. But I'm not aware of anything right now that's particularly taken off in the field of congenital.
So I think the ACHD colleagues will still have a job.
Yeah, hopefully I'm good.
It's a very high cognitive function as we one of the, as far as I'm concerned, the ultimate kung fu in terms of echocardiography. And it's like have to get all the puzzles together in terms of what connects to what.
Yeah, but it's not that complicated once you know.